Thank you, Juaria. Thank you. Good afternoon, everybody. I want to thank and congratulate the organizing committee on this conference, and I'm honored to be here today to talk about unique cardiovascular risk factors in women. So we'll start off with a case. This is a 42-year-old woman who had 2 pregnancies, 2 deliveries, and her last pregnancy was complicated by gestational hypertension, and she presented to the cardiology clinic for palpitations. Her exam was remarkable for her being overweight. Her blood pressure was elevated at 132/88. Her ECG was unremarkable. And for her labs, you could see her LDL was elevated at 132. She had an optimal HDL. So I just want you to think about how would you assess this woman's cardiovascular risk, like using her traditional and newer, more novel risk factors. So when we look at cardiovascular risk factors in women, you can think of them as 3 broad categories, and in the heart of it, we still put a lot of weight on traditional risk factors because they remain more predictive of cardiovascular outcomes, and they're still in the risk calculators. But even though men and women share the same traditional risk factors, they impact women differently, particularly diabetes, hypertension, obesity, and smoking, which I'll show you in a few minutes. And then there are conditions that are more predominant in women, so they disproportionately impact women, such as inflammatory diseases. So for example, women are 9 times more likely to develop lupus compared to men, and we know that the more active the inflammation, the longer the duration of the disease, the higher the risk of cardiovascular disease. And similarly, anxiety and depression have been linked with cardiovascular disease in women and have been linked with adverse, worse outcomes in women. And then we'll focus most of the talk today on the outer circle, which represents risk factors that are unique to women because they predominantly impact the OB-GYN realm. So, as I mentioned earlier, we always start off with the traditional risk factors because not only are they more predictive, they're also more prevalent in women. So 80% of women will already carry a traditional risk factor by the age of 40. And as I mentioned earlier, they impact men and women differently. For example, diabetes will increase the risk of heart disease in women 3 times, whereas it doubles it in men. So a woman with diabetes is 3 times more likely to develop cardiovascular disease. She's 5 times more likely to develop heart failure, particularly heart failure with preserved EF, and to develop ischemic heart disease and even cardiovascular mortality than men. Smoking, fortunately, is not very prevalent in women in the region. However, think of it especially in your younger patients. So in women younger than the age of 55, the risk of MI is increased 7 times compared to non-smoking women. And then hypertension is really an important risk factor in both men and women. So when we think about cardiovascular disease, it's very heterogeneous. And it remains the leading cause of death in both men and women worldwide, including here in the Middle East. And if we look at what do women die from, this is data from the Global Burden of Disease region, and if we look at the Middle East and North Africa, which is represented by the 3rd column here, you can see that the leading cause of death in women is ischemic heart disease. It is followed by stroke and hypertensive heart disease. So valvular disease, cardiomyopathies, arrhythmias contribute to less mortality cases. And if we look at risk factors that contribute to ischemic heart disease and cardiovascular mortality, again by region from the same study, the Global Burden of Disease, the Middle East here is represented by the 2nd column. You could see that the leading risk factor that leads to cardiovascular mortality in women is hypertension, and it's followed by hyperlipidemia. So the most important modifiable risk factor in women remains hypertension. And hypertension presents differently in women. So before menopause, we start with lower blood pressure than men. And in general, we see an increase around the menopause transition. And this is data from the US looking at the prevalence of hypertension in men and women and by age. And you could see that before menopause, more men have hypertension than women, but above the age of 60, hypertension really becomes a female disease, with 2 out of 3 women having hypertension. And And the investigators here looked at this, the incline or the trajectory of blood pressure in men and women. And I thought it was very interesting because, again, you could see that men, if we look at the graph on the upper left side, men as represented by blue, you could see that they have this gradual increase of blood pressure over time. Whereas in women, again, we start with a lower systolic blood pressure, we end up with a higher systolic blood pressure, and we see this very steep incline around the menopause transition. And that's illustrated again here on the right, where you see this steeper incline in blood pressure. Does it have any clinical significance? We don't know. No, we haven't really looked at that yet. And what is a normal blood pressure? So we look at the guidelines. We use the same thresholds and cutoffs for men and women. So in the 2017 guidelines, we use a cutoff of 120/80. The blood pressure of 120 to 129 has been redefined as elevated. And in the European guidelines that just came out last summer, they actually deliberately termed the blood pressure below 120/70 non-elevated. So it's not normal because we don't really know. You can still see an increase in cardiovascular disease with blood pressures within the normal range. And this is an interesting study that was published a few years ago that looked at the sex differences in blood pressure associations with cardiovascular disease in healthy men and women. So the authors here looked at a large patient population from 4 large cohorts. Half of the participants were women. And surprisingly, what they found was that you start seeing an increase in cardiovascular disease in women that is statistically significant at a normal blood pressure, at a blood pressure of 100 to 109. So this is surprising. So a woman with a blood pressure within normal range is at the same risk of cardiovascular disease as a man with stage 1 hypertension. And again, you see the same thing for MI, heart failure, and stroke. So this should make us just reflect about, should we be looking at sex-specific blood pressure differences? Should we think about different thresholds for men and women? Moving along to the risk factors now that are unique to women, and there's a few. So we'll start off with menarche. So I don't know how many of you here ask your patients about when they started their first period. Women usually remember it. It's an important time in their life. It signals the beginning of a reproductive stage. And the average age is usually 12, and there is a U-shaped relationship between the age of first menses with cardiovascular disease, with a younger age, which we're seeing more and more common, associated with a higher risk of cardiovascular disease. And that's felt to be due to higher rates of obesity in those girls, subclinical inflammation that might increase the risk of metabolic syndrome and cardiovascular disease. And similarly, a very late onset of menarche is also associated with a higher risk of cardiovascular disease. Usually it portends underlying PCOS or endometriosis that have been linked with a heightened risk of cardiovascular disease. So polycystic ovary syndrome, as you know, is not uncommon. It can impact around 5 to 13% of our female population during their reproductive years. And it is defined by the presence of polycystic ovaries, but also the metabolic syndrome. So a lot of those patients have high blood pressure, high triglycerides, obesity, hypertension, and because of the metabolic syndrome, they're at a higher risk of cardiovascular disease. So all these patients need to be tightly screened for cardiovascular risk factors and disease, and need to be counseled for avoiding tobacco use, exercising, maintaining a healthy weight, etc. And if there is any cardiovascular risk factor present in those patients, they do benefit from metformin. And pregnancy. You know, when we think of pregnancy, or I've heard the term that pregnancy is nature's stress test, because there's an increase in blood pressure, there's an increase in heart rate, but I think it's more than that. It really is a window in a woman's future cardiovascular risk, because pregnancy, or at the heart of pregnancy, you have a vascular organ, right, the placenta. So a lot of times it can be the first time the patient gives you a clue that they are at a higher risk of cardiovascular disease. So adverse pregnancy outcomes include hypertensive disorders of pregnancies, gestational hypertension, small for gestational age, early delivery, and spontaneous birth losses. And all of these are linked with an increased risk of cardiovascular disease. And the more frequent APOs a woman has, the more severe the APO, the higher the risk. So hypertensive disorders of pregnancy are the most common of the adverse APOs, and they complicate anywhere between 5 to 10% of pregnancies, and we're seeing an increase in the prevalence due to later, older age at pregnancy and other comorbidities. And it's divided in 4 categories depending at the gestational age of diagnosis of hypertension and whether or not there's any end organ damage. So usually 20 weeks is the cutoff. So if blood pressure is there before the 20th week or after the 3 months postpartum, it's usually chronic hypertension, and gestational hypertension is diagnosed between that 20-week period and the 3-month postpartum. And we use the cutoff of 140/90, and I hope I convinced you that's too high a blood pressure to diagnose hypertension. And we should be using a much lower blood pressure, because if you think of a normal pregnancy, you normally see a drop of 10 millimeters of blood pressure during the first and second trimester due to that decrease in vascular resistance. And normally we start seeing an increase in blood pressure around delivery and then in the postpartum period. And hypertensive disorders of pregnancies are not benign. They carry a lot of, they increase the risk of short-term complications, and as I'll show you later, even long-term complications. So women who have chronic hypertension or gestational hypertension are at a higher risk of developing preeclampsia, eclampsia, postpartum cardiomyopathy, heart failure, stroke, and even death. And the risk continues in the postpartum period. Actually, the majority of cardiovascular maternal deaths occur in that postpartum period, when unfortunately a lot of women stop following up, are not being seen in clinics. So, and there was always this concern about treating hypertension in women. The fear was that we would be inducing or causing uteroplacental hyperperfusion. But this is an important study that was published in the New England Journal of Medicine back in 2022, the CHAP trial, that looked at pregnant women with chronic hypertension and whether or not it was safe to treat their blood pressure to below a target of 140/90. And not only was it safe in terms of like fetal outcomes, but it actually was associated with a lower risk of preeclampsia. So we should be treating our patients during pregnancy, and we should be following them up. So before their discharge, it is important that they realize that having a history of HDP or any adverse pregnancy outcome does not end with the delivery of the baby. These women have basically flagged themselves as higher risk, and they need to be assessed and followed up in a cardiology clinic or by a primary care doctor, because they carry long-term risk of cardiovascular disease. And this is an interesting study looking at data from the UK Biobank. When women were enrolled in the trial, they basically, if they mentioned that they had a history of hypertensive disorders of pregnancy, they were much more likely to have hypertension than their non-hypertensive counterparts. And look at the difference even at age 65 or 69. So even 20 years after their delivery, if they had a history of HDP, they were still at a much higher risk of developing hypertension. And also from the same study, they were at a higher risk of developing coronary artery disease, heart failure, particularly heart failure with preserved EF, and even aortic stenosis and mitral regurgitation. Similar findings were noted looking at data from the Nurses' Health Study. So here there was a higher prevalence of HDP in those patients, 12%, and they were followed for 20 years. And again, you see that the women who reported a history of hypertensive disorders of pregnancy were significantly more likely to develop cardiovascular disease, whether it be CAD or stroke. And what was interesting in the study is they kind of separated the type of HDP and the type of cardiovascular disease, with women who developed preeclampsia more likely to develop coronary artery disease, and women who had a history of hypertension more likely to develop stroke. Why is that? Well, that's an interesting question. So even though these patients present clinically later in their pregnancy, the pathology starts at the very beginning. So the shared pathology between all these clinical entities is that there's placental malperfusion or placental abnormal placental implantation with abnormal spiral arteries that leads to an increase in anti-angiogenic proteins. There's an increase in inflammatory cytokines that clinically will manifest later as one of the adverse pregnancy outcomes. And this illustration kind of puts all of this together. So a lot of these women might have traditional risk factors that ultimately will increase the risk of cardiovascular disease, but not necessarily, right? Sometimes you can see a young woman during her first pregnancy develops preeclampsia with no traditional risk factor. But either way, in addition to that, they have this abnormal placental implantation with vascular abnormalities that clinically manifests itself as adverse pregnancy outcomes, and if left unchecked, will present itself or contribute to overt cardiovascular disease years later. And what's interesting is there have been some studies that looked like at echo being performed early in pregnancy, and showing that some women will develop diastolic dysfunction before they go on to develop preeclampsia. So preeclampsia is usually like a end of term or at term complication, but even earlier in those pregnancies, these women had abnormal markers of inflammation, abnormal anti-angiogenic proteins in their circulation, and even diastolic dysfunction on their echoes. So something happens very early on. And in this Scandinavian study, they found that women who had a history of preeclampsia were actually more likely to develop or to have atherosclerotic disease, asymptomatic atherosclerotic disease on cardiac CT compared to women who didn't. And in our women's clinic, not only do we ask patients about their pregnancies, it's also important to ask them about their miscarriages, whether or not they had difficulty conceiving, because we know even infertility, which I'll show you later, has been linked with cardiovascular disease. In this data from the Nurses' Health Study, they found that any history of miscarriage, particularly if it happens later during the pregnancy, so usually miscarriages that occur during the first trimester are very common. They impact around 20% of women. They're usually thought to be due to fetal chromosomal abnormalities, but miscarriages that happen later during the second and third trimester may be due to placental abnormalities, again, denoting a higher risk of cardiovascular disease in women. And that's why also in younger women in whom you wouldn't expect fetal chromosomal abnormalities, if you're seeing a young woman with recurrent miscarriages, particularly late, that should be a red flag. It's a sign of some microvascular dysfunction or endothelial dysfunction. And similarly, infertility, like I said earlier, or the use of ART has been linked with an increased risk of cardiovascular disease. It may be partly due to a lot of those women might be older and may carry other traditional risk factors. And not only are they at a higher risk of developing cardiovascular disease, but specifically heart failure with preserved EF. So in this study from the Women's Health Initiative, they found that there was a statistically significant increase in the risk of HFpEF, which we predominantly see in women. And I think the link that what can link the two together might be some microvascular dysfunction that might explain why we see both of them. And in the last few minutes, I'll just talk about the menopause transition, which is another important phase in a woman's life. And the menopause transition, you know, when you think about menopause, it's defined as 1 year of amenorrhea, but it's preceded by years of perimenopause, right? And that can be as long as 10 years. Usually women are felt to be protected from heart disease, and you see that 10-year lag. Women typically present with cardiovascular disease 10 years older than men, and that is felt to be due to the cardioprotective benefits of estrogen that we unfortunately lose during menopause. But we're also older during that time, so it's hard sometimes to tease out what is due to chronological aging versus just ovarian aging. But menopause is associated with many changes to a woman's body. There's a change in the fat distribution with more central adipose fat. We start seeing an increase in LDL, increase in lipoprotein little a, an increase in blood pressure, which I showed you earlier, due to an increase in the renin-angiotensin-aldosterone system. So there's a lot of changes that happen and a lot of symptoms, including palpitations. So if you have a patient who presents with palpitations to your clinic, think about perimenopause, even if they're 40. like again, perimenopause can present 10 years before. So menopause, whether it's natural or surgical, is associated with a higher risk of cardiovascular disease, and I believe I'll end here. Thank you. There's a more and more interest in menopause recently. And if you think about it, actually, most of a woman's life is spent in post-menopause. So I think it is important to know more about it. I only had a couple more slides anyway. So it is important to realize that when patients have early menopause, so the average age, as I mentioned, is around 50, 52. Early menopause is considered or defined as menopause before the age of 45, and it affects 10% of women, so it's not insignificant. And premature menopause is defined as menopause before the age of 40, and both are associated with an increased risk of cardiovascular disease, as I mentioned earlier. And one of my last slides is to talk about chemotherapy-related cardiovascular disease. I mean, this is a topic on its own. I'm not going to go into details, but it is important to be aware of any history of breast cancer or cancer in our patients and the therapies they've received. Fortunately, more and more of our patients survive their breast cancer, and now they die from cardiovascular disease. So it is important to know their therapies that can lead to cardiomyopathies, hypertension, and other cardiovascular complications. And to conclude, I just wanted to share this nice illustration from the Canadian Women's Heart Health Center that kind of puts all the risk factors in one image, and it shows you that a woman's journey with cardiovascular disease changes right over time. But our risks, and we already provide information to our physicians as early as during our teenage years. It's important for us to ask our patients about their cardiovascular history and to be aware of these risk factors. And with that, I'll end here. Thank you very much.